Welcome back to What the Heck? Health Education and Conversations, a podcast by the Oregon Primary Care Association. Here, we explore the health policies, partnerships, and care teams shaping community health across Oregon. From healthcare delivery to workforce challenges, each episode features conversations with primary care leaders and partners that inform, inspire, and spark the transformation of care to sustain a reliable, high-quality network for those in the most need. If you've been following along, previously we talked about the federal 340B drug pricing program and how eligible healthcare providers, referred to as covered entities, provide these medications to patients. During that conversation, Josh Free, co-founder and president of RxFusion, shared his background in pharmacy, his firsthand experience learning about the 340B drug pricing program, and what led him to assist healthcare providers set up physician office dispensing at their sites. Today, we're taking a step back to reflect on what we heard, highlight the moments that made us think twice, and the insights that are too significant to let pass by without a closer look. Before we dive in, I'd like to thank the physician office dispensing experts at RxFusion for making these conversations possible. If you're looking to improve patient outcomes, speed time to therapy, and improve revenue, RxFusion allows you to dispense medications directly in your practice, boosting satisfaction for both staff and patients while saving money compared to contract pharmacy. I'd like to introduce one of my colleagues here at the Oregon Primary Care Association. Marty, will you please tell us a bit about yourself?
Thanks, Dani. I'm Marty Carty. I'm the Director of Government Affairs here at OPCA. In that role, I have an opportunity to work with our health centers on things related to policy, regulatory, and we can talk more about it later, but I get to work a lot in the pharmacy space. And that's really a good segue into how I became part of our 340B subject matter area expertise here at OPCA. About 2 years after I started here at OPCA, a former staff member who was managing and supporting our FQHC pharmacy leaders left the organization. And, 501c3s, membership associations like OPCA, oftentimes folks wear many hats. And there wasn't anybody who was raising their hand and said, I'll take over this leadership group. And so I jumped into that. And it's been a fantastic and also wild 5 years of supporting that group. As we'll talk about a little bit, Josh talked about the landscape in the pharmacy environment. It has really changed in the last 5 years, not only in the state of Oregon as it relates to pharmacy closures, and our state has a number of pharmacy deserts, but also the 340B program shifted significantly in the last 5 years. And so getting to be part of that and learn has been really great.
Some folks may know that I used to work for OPCA a couple of years ago in a different role. And almost 2 years ago now, I've come back as the communications manager. And I will share that when I was re-educating myself, 340B was one of those subjects where I was both intrigued and overwhelmed at the same time. So I have a lot of respect for anyone who really lives in this world of 340B because there is a lot of complexity to it, but overall, the goal that this federal program has is crucial because its aim is to increase access to life-saving medications for those in the most need. It's really impactful, but there are some pieces a lot of folks have to navigate to make sure that it's continuing that legacy of the program.
As I'm thinking about the interview you did with Josh, it's always fascinating to me to learn about someone's background. And I think the concept of office dispensing really is patient-centered. I think about the healthcare system as a board game, in that there are many steps that are required to get access to the various aspects of healthcare. If you have insurance, you have to make sure that you go to the right provider that's covered by the insurance. And then you have to make sure that the things the provider wants to prescribe are covered and don't need prior authorization. And then once all those things are done, then if there's a prescription, well, then you have to go to the pharmacy counter, which is maybe a different building. So there's all of these steps before you can get to the ultimate goal of good health, right? This office dispensing model that Josh and RxFusion are driving toward just eliminates one of those steps for the patient. And what a win. If we can bring the medication to the exam room for the patient, that eliminates one of those board game steps that they have to go through to achieve their definition of optimal health.
So, just to get a little bit of an understanding of the landscape here in Oregon, Marty, I'd appreciate you to give us a little bit more context.
Yeah, Danny, every state's 340B landscape in terms of the organizations that are eligible to participate in the program is different. In the federal statute that created the program, there is a fairly long list of eligible organizations. In Oregon, we have a Ryan White Clinic, we have federally qualified health centers, we have Indian Health Services or Indian Health Centers, and then hospitals. That makes up the bulk of the covered entities in our state. Diving in or zooming in a little bit for the FQHC, Josh talked a little bit about the two models for dispensing drugs to patients. You have either an in-house or entity-owned pharmacy, or you contract with pharmacies to dispense drugs on behalf of the covered entity. For FQHCs here in Oregon, there are 20 that have an entity-owned pharmacy or operate their own pharmacy program. I think the remainder of our members, that's 13, use contract pharmacies, but that's not exclusive to that group because just sort of the nature of how patients want to access pharmacy services, right? So an FQHC might have its own pharmacy. We have to recognize that's located in one place. And it may not be convenient for a patient to drive or use the bus or walk or however they get to their healthcare provider to go to that location to pick up their prescriptions on an ongoing basis. It may be much more convenient for them to use a pharmacy that's closer to home, closer to work, closer to where their kids go to school, whatever that looks like. Health centers recognize that they may serve patients across a wide geographic area and they have an in-house pharmacy, but requiring that patient to come there to access their medications every 30 or 60 days could really be a barrier to medication compliance. So almost all of the health centers in the state that have their own pharmacies also contract with pharmacies to extend the reach of access to prescription drugs. Medication compliance is super important. It improves outcomes, drives down cost. So without those pharmacy partners, patients accessing medications can be a real barrier.
You made a really, really good point, and I want to make sure that folks understand what you just said. There are multiple models on how you deliver these medications to patients. As you mentioned, in-house pharmacy, contract pharmacies, and also office dispensing, which we just learned about recently, that many health centers will actually adopt multiple models in order to really make sure that the systems they're using are effective in getting these medications to patients, which is the whole point. Because when an individual is living with a chronic health condition or other health needs that they have, it's really essential for them to manage their health, to consistently access their medication, or at least have a care team that can assist them in making sure that they're taking these medications regularly. So it's really helpful to understand when you're considering how to deliver these medications within your own primary care setting, that you really think about what's feasible for your organization, what's feasible for the amount of staff that you have, and then also understanding overall the impact and value that you're bringing to your community. Here at OPCA, we facilitate member groups for those who work at health centers to network with fellows who share a similar role at their health center. And one of those groups are the pharmacy leaders group. With that in mind, because of the fact that you facilitate the pharmacy leaders group, what have you heard the pharmacists mention being challenges or other pieces that they wish they knew how to navigate 340B better?
The one thing that every FQHC pharmacist that I interact with say about the program is the 340B drug discount program improves access to life-saving medications. Now, there's a fair amount of complexity, but that complexity shouldn't be seen as a barrier. The reason that there is that level of complexity to the program And as Josh said, he went to the Apexis 340B University. And everybody who works at a covered entity like an FQHC or a hospital or a Ryan White clinic or a tribal setting who interacts with the program needs to understand how it works. And the reason that's so important is because the federal government's role in oversight is robust, and compliance with regulatory requirements is really important. Covered entities like health centers are bound by both federal statute and HRSA, Health Resources and Services Administration, to reinvest 340B savings back into patients. And so that's something you can't just say you do. That's something that you have to demonstrate that you do. And so when health centers are tracking their program, they have to account for that. And that's something that's very unique to health centers and other federal grantees like health centers. So, Josh mentioned another line of business. He's been in the 340B program for a long time. His other business is
Nelco Advisory.
Right. Yeah. And they help health centers with making sure their 340B program is following all the rules and regulations that the federal government has. Another thing I hear is that the 340B program, as established by Congress, as complex as it may or may not be, every health center would tell you the program makes sense. The intent of the program, as articulated by Congress, is to stretch scarce federal resources. And the complexities and the compliance and all of those pieces as just sort of like the cost of doing business, because the benefit is so great for the patient.
A pharmacy is its own business that you have to make sure that it's running smoothly on multiple levels. And Josh also mentioned shortly after he left pharmacy school, he had that opportunity to move into a management role, and how early on in his career, he understood the patient experience was crucial in order to establish that relationship and have those points of engagement with that patient. So when you think about a pharmacy as a business, it's really important to think about the purpose of 340B, how it does have a focus on the patient, but really focusing though on the systems level of understanding how can you get the medication to the patient, then what are the pieces that have to go into that delivery. Were there any other points that Josh made that you found really interesting?
At a time when we talk about the cost of prescription drugs, it's everywhere, whether you're listening to the current administration about prices of drugs as it's compared to other countries, or whether you are a little more zoomed in locally, the reality is the cost of prescription drugs just continues to inflate year after year at a pace that is far greater than many other aspects of our economy. And so the 340B program and office dispensing coupled together can really mean better access to prescription drugs at a much lower cost for the patient. And when I say cost, I mean, sure, there's, whatever they pay out of pocket, whatever their insurance covers, those pieces, but also just in terms of, I've got 2 small kids. Adding one more stop in my day means I have to unbuckle 2 car seats. I have to get 2 kids out of the car. That seems very simple. And yet extrapolate that to if you don't have a car, or if you have work and then pick up kids from school, and all of the things that we have in our lives, we're just adding another layer to that. And so this concept really centers the patient. I'll also say that from a covered entities perspective, the health center's perspective, covered entities pay fees to any number of vendors that they engage to help them manage the 340B program. But that's not unique to 340B. Healthcare providers on the whole, across the spectrum, pay any number of vendors to help them run their businesses. They outsource services like janitorial, accounting, human resources, security. There's no shortage of examples of how other primary care practices outsource certain services. Oftentimes, the reason that we outsource to a third party is because it's more cost effective. And if we don't have that vendor to help support the program, then we don't have access to the program. And if there's not access for health centers to use the 340B program, then we can't get patients the drugs that they need at a reasonable price. And that's what the 340B program does. That allows health centers to reduce the cost for the patient, to improve access to healthcare for the patient. At the end of the day, that's who we're centering, but we have to pay for that. That was Congress's intent, again, was to stretch scarce federal resources. And so bringing office dispensing into the picture is one way that health centers, as Josh pointed out, we're using existing staff roles. And I get it, everybody's busy, but layering on office dispensing shouldn't be a significant burden, particularly with a partner like RxFusion. And at no real additional cost other than, again, you're working with a vendor, but that means you're able to bring some of the costs in-house and avoid that contract pharmacy professional dispense fee on some number of drugs. Another thing that Josh pointed out, and we've talked about it here a little bit, is medication compliance. Another big reason why RxFusion and implementing office dispensing makes a lot of sense. Knowing that your patient started that new medication is critical for better outcomes. It saves the whole healthcare complex money down the road. And for FQHC patients, office dispensing means the FQHC can make decisions on the spot around how to financially support the patient. They can assess what cost barriers exist so that the patient can access life-saving medication. That's not always the case when the patient has to go outside of the FQHC to a contract pharmacy to get their medication, particularly at a time when many drug manufacturers have imposed contract pharmacy restrictions on covered entities. When manufacturers ostensibly control which pharmacies FQHCs can contract with, that makes it hard for them to help patients with the cost of their drugs. Health centers are on the front lines of providing access to healthcare for the most vulnerable Oregonians. And again, centering those humans is the most important thing we can do.
Bringing this back to when you were talking about barriers, we often talk about transportation because it is one of the key barriers, especially when we're talking about having to travel to meet with your primary care provider. But I think another one that is really important to point out as well is language barriers. Again, when someone is choosing a provider, they are looking for someone they can easily communicate with. Sometimes language comes between that, and office dispensing can be really helpful in that respect.
Our state has done a really nice job of ensuring that patients have access to healthcare in the language that they prefer. Our state has a meaningful language access law. And so that means that patients have the right to have an interpreter or have a provider who is certified by the state who is competent in the language that the patient prefers. But your point is that oftentimes a patient might choose a provider because that provider is competent in the language the patient prefers. But the pharmacy counter, there may not be someone there who in person in front of you is also competent in the language that you prefer. And so then you have to insert a translator. And while that's certainly great for the patient, adding a third party in the loop can make that feel more transactional, less personal, less confidential, any number of things. But yet, when you're sitting with your primary care provider in that exam room and you're able to have a conversation that you're comfortable with, you may share things that you wouldn't if there's a third party. And so I think that to the extent that RxFusion model of office dispensing, that we can keep those conversations between the patient and their primary care provider, particularly someone they're comfortable with, makes an enormous amount of sense. I don't want to discount the value of the pharmacist and the pharmacy counter. Pharmacists and pharmacy services are as important in the patient's healthcare delivery team. And pharmacists play a critical role in medication compliance and counseling and testing and treating and so many other things.
That point is really crucial for primary care settings, especially health centers who have smaller teams, may not have a pharmacy team at their health center. This could be a great resource, being able to enhance the health center's capacity to deliver healthcare to patients. Reiterating that point made earlier that there are multiple models and how you deliver life-saving medications to patients. It's really up to the health center, the primary care setting, wherever you are serving patients, for you to really think about these models and understand what fits your own model of care.
Every health center in Oregon knows what it means to look a patient in the eye and tell them that care is possible, that the door is open and the treatment they need is within reach. This promise between healthcare provider and patient is strengthened by the federal 340B drug pricing program. The 340B program has given health centers across Oregon and this country the resources to keep medications affordable, keep doors open, and provide patients in the most need with care. A shift to a rebate model would change everything about how health centers serve those patients. When access disappears, patients suffer, and our communities feel that loss together. The Oregon Primary Care Association is amplifying the voices of federally qualified health centers to members of Congress who have the power to protect this program. And we need yours. If you want to share what 340B means for your patients, your community, and the care you work so hard to provide, reach out to Marty Carty, OPCA's Governmental Affairs Director. Share your experience and take it to the Hill to elevate your story to the lawmakers who need to hear it. If you don't want to miss the next episode, make sure to subscribe to this podcast to receive notifications of when new episodes are released. Today's conversation was produced and edited by Dani Gehrke and fact-checked by Priya Thorin, who also helped with research. I'm Dani Gehrke with the Oregon Primary Care Association, and thank you for listening.